you put your camera on and then we can all see you. So that'd be great. I don't think there's anything else to do around how we function this morning. Welcome to our, got 3 governors with us this morning. Thank you very much for being here. And also Lynn, I think, is here to do the presentation a bit later on in the agenda. So any apologies for absence, possibly Mark Basalian, he would say, oh, Ken, Ken, sorry, you're online. You may have just missed. We had some feedback that if people online could just keep an icon rather than their camera on, it just enables people to see a bit more of the room. Thank you very much. I don't mean to be antisocial. Yes, apologies. Mark Basalian may not be here this morning. He's got another meeting first thing, but he might be joining us online. But just to note that. Any declarations of interest at all? Thank you. So following that, we just go over to the patient story. So, Tanya.
Everyone, my name's Lynn. Thank you for inviting me to share a patient participant story. So I'm Deputy Head of Research and Development. This story will be about one of our research participants here in the trust. So just a little brief context first. The department has 25 members. We have the head of department, deputy, 18 clinical staff, and 5 governance staff. Our aim is to provide impactful, high-quality research that allows our service users and patients to have access to novel therapies and care options. This is increasing their engagement and involvement in their health now and in the future. I have the NIHR logo at the top here because our funding stream for the team is from the NIHR.
Sorry to interrupt, can we also show the teams?
Yes.
Okay.
So this slide just briefly shows the recruiting studies we have. On the left, the year 22-23, and on the right, 23-24. This is benchmarked. So this shows the equivalent size trusts. And we are third in our placement across both. We have 290 studies on the portfolio, and we cover 24 of the 30 NIHR specialties. So our number increased of open studies by 20%, and the complexity of the studies has increased by 5%. Our commercial studies, which is the orange end to the bars, has reduced from 6 to 1.7. This is important because it's beneficial both to patients and the trust, because on average for each patient recruited into clinical research, not only do they get the novel therapies, but the trust, the NHS provider, receives approximately £9,200 per participant and makes savings of £5,800. Studies by the NIHR have shown that over a 4-year period, the commercial recruits have reduced from 50,000 to 28,000. So there are the impact of that. Here we have our recruitment figures. As you can see, we were the highest recruiting trust when benchmarked in 22-23. This year, currently we're third because we've had some higher recruiting studies close, but our complexity has increased, and we're still being approached as we are the highest recruiting for individual studies, and we're being asked to buddy other sites to help them increase their recruitment. So I'm now focusing on one study. It's a children's radius acute fracture fixation trial. It's a multi-centre trial across 32 sites in the UK. Prospective, randomised, non-inferiority, looking at surgical reduction versus non-surgery casting in 4 to 10-year-old children. They're looking at recruiting 750 children over a 2-year period with a 3-year follow-up. And of those children, 200 will have a complete upended fracture, which we'll go on to in a moment. This question is one of the top 5 questions from the British Society for Children's Orthopaedic Surgery, and so it's really relevant at the moment. The next slide do concern fractures, so if you're not sure about fractures, okay. So this is one child, a 7-year-old female who was taking part in the study. As you can see, the fracture is completely off-ended because the ends don't join. So in the UK, we're almost universally surgical intervention. There's only one site in the UK that offers routinely non-operative care for these children. And that site is Nottingham. It's led by Sir James Hunter, who's also the Get It Right First Time UK lead for children's orthopaedics. The hospital episode statistics say that there's 2,500 children every year who go to surgery. That's not day cases, that's not the ones that are fixed in ED with analgesia, and that's a cost of approximately 4 million to the NHS. This is another 4-year-old male, again, significant fracture of the distal radius. He went to theatre, general anaesthetic, they pulled the bones back into place. So now these children were randomised to non-operative care. Nothing was done for these children. They had 2 fingers held and a cast applied to their arm. No reduction, no theatre, no anaesthetic. After 6 months, the bones are starting to align naturally because they remodel. And they can remodel for up to 2 years. And again, a 7-year-old male, nothing was done except for a cast, and at 9 months you can see even the slight bend of the bone is correcting. So this is important, this study is important because there's safety in research. There has to be a valid question, it has to go through the literature review, the ethics, the governance. And for this study, there was the Young Persons Advisory Group who was supported by the NIHR across the country, who were involved in making sure that the information put out there is age relevant for the children, so that the children can be involved and informed about what's happening and can make their own decisions as to how they feel about the study. So we're not exposing children to harm. The other thing about it being part of research is that we're monitoring for adverse events, serious adverse events. And if it was found to be at all harmful to children, the study would be stopped. Okay, so now Sam. Now the reason he's blurred out, I contacted his mother and she gave me permission to share this within the board. I hadn't realised at the time he didn't share it externally. Because I haven't been able to go back to her and confirm that she's happy for it to be external, I've made the decision just to protect his identity. So Sam is a 10-year-old boy. At the end of last year, he had a fall onto his outstretched arm whilst playing football at school. So this is his X-ray when he came into our paediatric ED here, and identified him as a potential recruit for the CRAFT study. A member of the orthopaedic team who clerked him mentioned the study to Sam and his mum, and they gave their consent for the research to also visit and discuss the study in further detail. But in the meantime, he was clerked and admitted for theatre for the next day. He was admitted into the trust. Sam, understandably, was quite shaken, quite reluctant to go to theatre. It's quite a big thing for a child, especially this age group between 4 and 10. And for the parents taking the child and handing them over. I said, wow. Fortunately, mobile phones with games on them and the therapy dogs are a great distraction for these children. So Stan was admitted onto the ward. The next morning, the research nurse spoke to his team first. There was some concern because the fracture was quite close to his growth plate. But there was a discussion saying that he does meet the inclusion-exclusion criteria for this study, and therefore the decision should be the families. They should be involved in that choice. So the research nurse spoke to Sam and his mum, and using patient information sheet for the correct age range. There's an online video and there's a booklet, so it's very visual as well as words. And so they were given a balanced view, told it's completely voluntary, all research is completely voluntary, and it's a randomisation. So Sam, with his reluctance to go to theatre, he still couldn't be guaranteed non-operative. That's the whole thing about research, but it did give him a 50% chance of not having the operation, which if he weren't in the study, he wouldn't get, so it automatically theatre. So they made their informed decision. They were given time to think about it. The research nurse went back and spoke to them, and Stan gave his assent, being under 16. So he's made his agreement based on the information that he received, and his mum gave the overall consent for the study. They were randomised, and much to Sam's pleasure, he got non-operative. So his cast was changed and he went home. So the outcome of this, meaning we have reduced length of stay, reduced bed occupancy, the potential reduction of £1,600 in the trust because there was no need for theatre, and most importantly, Sam was very happy. He was a very happy young man. And he was empowered, you know, he was involved in his care decision. He was given the information, he was allowed to make his voice be heard. So this was the fracture after 4 weeks. You can see that it's starting to have new bone growth, it's starting to remodel. And under the slight blowing, there's a big beaming smile. And the mum sent me this video. Fantastic. So why have I chosen this story? Research is about patients first. It's about empowering patients, it's being patient-centered care, involving people in care decisions and having that option. If this research study wasn't open in this trust, Sam would have had theatre. So it's not saying all children have to have non-op, but it's allowing people to make a decision about their care. And it's showing people that they can be involved and they should be involved. So the NIHR Involved project is looking at underserved groups, looking at children, especially because we don't have so many children in research as compared to adults. So we've also gone out to, I've approached schools and I've given some teaching sessions in school and scout groups to just talk about research so that most children come in through ED and they're prepared, they have an idea. So if someone speaks to them, it's not a completely new concept for them. Generation R is an NIHR funded young people improving research, so they help with the information sheets. The BLM case strategy is about supporting people to engage with their care, which is what we're doing in this case. And of course, just shared decision making, GMC, NHS long-term plan and the Health and Care Act all support shared decision making. So instead of the clinical team saying this is what needs to happen, we're bringing in that option and involving the patients more. And of course, the potential cost savings. So my last slide, research is win-win. Patients get options, they get the most effective treatment, they get increased understanding of their condition and involvement in their care, and they have increased knowledge and engagement. For clinicians, we're encouraging that curiosity. So rather than, oh, I've done it like this since my training, it's like, do I need to do it like this? Is this the best way? So we're encouraging that continual learning and that continual curiosity and evidence-based practice. And for the NHS, we have improved patient satisfaction, improved outcomes. We're reducing length of stay, interventions, follow-ups, and our cost and operational efficiencies. Thank you.
Thank you very much, Harry. Thank you. It's amazing. 212 has gone off for 3 years, so this is fantastic. Yes, so interesting. Yeah, it was a long time ago. But anyway, any questions? Okay.
Recovery times for children, is there a significant difference with them being left in the cast model versus the surgical model?
Sam's cast came off after 4 weeks. He is given advice not to swing from trees and you know, be particularly rough, but then he casts the same amount of time.
Very, very interesting presentation. Just a quick query around was one of the groups in the study you would say that they didn't receive any intervention at all, that their fracture was not reduced, or did I get that wrong?
No. So if I just quickly go back, these children have nothing done. They just have a cast put on.
Right.
They don't go to theatre. They don't have an anaesthetic. They have a cast put on.
Without reduction.
Without reduction. So this arm is put in a cast, and that's the same arm at 9 months. Obviously not in a cast for 9 months.
Of course. Thank you.
Yes.
So if I was bringing my child with a fracture to any trust, it's only the ones obviously who are involved in this research. And do they automatically get asked the question of whether or not they want to be part of the study?
No. So there's for all studies, there's an inclusion exclusion criteria.
Right.
So the fracture has to be significant enough that it would warrant surgery,
Okay.
because the randomization is surgery.
It's that threshold.
Yeah.
Everybody's given an option to come into the
There should
research.
be, yes.
The answer is interesting, but so they should be, but it does obviously depend on lots of different people never get that research.
Yeah, and that's what I was going to ask about communication. You know, what's the communication process with patients? But I'm also concerned about what's the communication across the clinician group.
Yeah.
Because, you know, there's a lot of change and churn and turnover. And
And
things.
that's inevitably a challenge. Maybe the best form of communication in this example would be at trauma meetings when the doctors are sort of reviewing the fractures the day before. They'll be talking about, oh, this is a case that's gone into the craft trial.
Yeah.
And then some another opportunity for education. That's a problem with, to be honest, all research studies.
But there could be quite a percentage that goes, let's do it.
So they could be. My view would be, because we're a single site hospital,
Yeah.
because in a team are such powerful advocates for research.
Yeah. Yeah.
Pretty good.
We have a very strong presence in your.
Yeah, but it will vary.
Yeah.
Yeah.
So this study was looking at 750 children that are missing, they need to recruit another 57, and they've met target. In October, they recruited 17 across the 32 sites. The chief investigator for this study is in Liverpool, and they recruit quite a lot of these Liverpools. It's well known throughout their department, but because we are small enough to know everyone in the orthopaedic team,
Yeah.
we can communicate well enough to get this out.
Yeah, it's two quick, that was a brilliant presentation. And then just two questions outside of it. Firstly, around the underserved groups, have the trust got a strategy around recruiting communities from underserved groups into research generally? And also, like with the NIHR model you talked about, have we got things in place for that sort of career, academic or research pathway for staff who are interested in that?
So for the underserved communities, yes, we won some contingency funding, and so we were able to go out into different communities. Barmy and Idris, the EDI lead, are already doing a lot of work into different cultural groups. We've gone out to disability groups and to children. So we've made those connections, and we've already brought people into the trust to support the initiation of Sign Life, for example. So we're getting that message about research out to these groups as well as the schools. In terms of the pathways, we do promote any option for grants and sponsorship by the NIHR for the through word of mouth and through the weekly message and things like that.
And are we able to, because a lot of colleagues, especially nurses and AHPs, they go on these programs and there's a drop off, they're not able to continue that research portfolio, which seems
It's
such a
very
shame.
difficult to balance clinical care and research.
Yeah.
This research is growing in its portfolio and its presence. We are getting everywhere. It is recognised as the value that it deserves, really. So it is always difficult when we have such operational pressures.
Thank you.
Peter.
Just ask half my question. It's reading the notes. Sorry. I absolutely love this presentation. Probably a little bit because I broke my arm 3 times in my teenage years, was operated on twice, and still had pins in there. So, you know, had this been around, probably felt a bit better. But my question was kind of similar. How do you balance the pressures with the operational work that needs to happen in the hospital coming into winter months, and the appetite to push forward on the great kind of research that we're doing?
We get a lot of studies coming our way from the research network. We screen them as much as we can. So we're looking for studies which are impactful, but are not too heavy on clinicians' time, and where we have how much follow-up is that, and can we do that online as opposed to requiring clinical space. So we're very much picking the best studies that suit the trust, our patient population, the priorities of care that we're looking at, and our ability to deliver them.
Ian.
So just on that, in terms of sort of balancing the different challenges, I've never met a group of research nurses, a research team as pragmatic as Liv and Antonella and colleagues. An example would be during COVID, where the research team essentially delivered our mask fitting and vaccination as well. And I think their approach is actually being clinically facing and being engaged with clinical teams on the wall, and just the way to recruitment. So it's very pragmatic that you need to be available in the clinical area. Therefore, if demands mean that you're more clinical and less research on a particular day, that's probably right.
Sense. Thank you.
We have, just to add to that, we have a study that's looking at strokes, and we have the bleep, so that when we have a red call, the mask goes down. But she's part of the team. She may cannulate, she may assist with the patient stabilisation, and then be picking up the information she needs for the inclusion exclusion criteria before approaching the patient or relatives. So we're very much, we're nurses, we're clinical. If we go in there and say, could you do this for me? Could you do this for me? We do it ourselves.
I was just going to ask the flip side of that question is whether the fact that we are a centre for research makes it a more attractive place and easier to recruit people, and you become a bit of it's a plus to attract people to come and work.
I've worked in research since 2015, and we really struggled initially to get people into research, partly because of the length of contracts, which has now been resolved. But now we're getting 14 applications per post for band sixes. And also we'll have people approaching us saying, I'm a lead consultant in cardiology, this is my area of interest. Have you got any studies into that? And we always respond, we can look for some.
Yeah.
If we have clinicians come to us with an interest, we can look to see if there's research that we can bring into the trust.
So there's wider benefits than just the direct benefits.
So I know I'm going to have to come and to see everybody again, and I'm really interested in this, so I won't ask all the questions I've got now. Only one quick one though. I suppose this is for young bones, is it, as opposed to older ones?
This is for 4 to 10 year olds.
Yeah.
Yes, but that's the
Well,
age where
Yeah.
theatre's most scary.
Yeah.
So
It's just very interesting. Yeah,
It's just that option.
be interesting to see, around what could be done for the older age group as well, because of course that's where we have so many effective people get older. So brilliant, thank you very much. That was absolutely fascinating. Okay. Right, okay, back to our agenda. Minutes from the last board meeting. Any omissions, inaccuracies that anybody wants to pick up? Was everybody happy with those? And we can Yep. Okay, thank you very much. Those are approved. Matters arising. The significant risk register 24.
And that on the risk report, just with time frame for delivery of the various bits of risk work that's going on.
Yeah. Very much. And then the CQC maternity patient experience update.
I think we did that at the new seminar last month.
Oh yes, sorry, that's completion. Didn't notice that last month. Right, anything that we might have missed? Matters arising. Yeah. Okay, thank you very much. Going on then to my report, also there's the written paper that's is in the pack, but just a couple of extras. Attended I think it was on Tuesday, the Black History Month closing meeting, and it was around empowering. Kate was there as well, and Joe. It was a fantastic session actually, and there was some very inspiring women from NHS England who were speaking to that as well. Lots of discussion coming out from that, lots of discussion around transformation and sharing of their own experiences as well, but also just stressing the high impact action plans come out from NHS England, which I know we're looking at ourselves to bring back, but also it's given me some ideas I will be discussing with colleagues around some board development going forward next year, and they were encouraging very much some board development around the issues they were raising. So that was a really good session. And then also just to say that the Integrated Care Partnership met this week as well. I sat in on that. Again, there was quite a bit of discussion around some of the initiatives in our system, in our Better Milton Keynes system, particular emphasis on some work in mental health services with the police force, because obviously nationally there's a change now in terms of how police will assist in times of crisis. And then later this month, there's going to be a strategic discussion day and focused on 3 to 5 year olds in preparation for children being ready for going into school. So there's quite a lot around that sort of broader public health work and population health. So There's been a bit slight hiatus with the partnership group. I mean, partly it's just getting, it's open to a number of organisations across the whole system. So it's trying to get times when everybody can meet. But anyway, it's moving forward. Okay, any questions? Thank you very much. Joe, going on to you.
Thanks, Alison. I'll just follow up on a couple of things that you said. Black History Month, I'd like to formally record our thanks to the BAME Network for all of the hard work that they put into organising a series of events. And also, I think we had Precious doing one of the talks for us. So that was extremely well received. So thank you there. And I think it really did do a very good job of raising the profile across the organisation. So big thank you formally to them. It was also Freedom Speak Up month this month, or last month, October. Busy month, lots of high profile actions taking place there to raise the profile and to continue to reinforce the voice of everybody in the organisation having that ability to speak up. And I think we'll come on to talk about some of the work, the additional work that we're doing. It's 1 year anniversary of our Maple Centre opening. And in that first year, we've seen 20,000 patients through the Maple Centre, and it's 20% of scale. And we continue to receive glowing feedback about not just the physical environment, but also the care that gets delivered. So big thank you to everybody involved in that. And we have also started our Protect and Reflect events through the Academic Centre, and we're using the tent today to make sure that all of our catering team can access Protect and Reflect. So we're trying to move it around the organisation so that everybody can access both getting their flu and COVID jabs and also being able to fill in their staff survey. So a combination of the two things there, which is really positive. I've got a couple of papers under my section as well. You will see that I am proposing to commission a series of external reviews and support for looking into the organisation through different lenses. I think if I go through them, the organisational cultural development programme, I talked about making sure everybody's voice is being heard. Subject to board approval, I am proposing that we invite Roger Clyde in, who's a recognised expert in this field. We have also approached Lord Adewale, who knows it on Coghill, who is another recognised leading expert in this field, to come into the organisation. Second piece of work, I am proposing that we do an external review of human resources. I think similar to different reviews that we've done across our organisation, like the IT one that's mentioned in the workforce paper. This is about making sure that we look at systems, process, and really difference between having a really good functioning department and having one that is gold standard in terms of everything to do with EDI. And proposing that we bring in again an expert in the field who is a case study and get subject to board approval. We have approached NHS England to nominate an expert in board governance to ensure that our board papers are covering the breadth and depth of the subjects that we are required to examine as a board. So we have had a name given to us, not anybody I know from NHS England. And again, subject to board approval for that process, I will go on and do that. And then finally, on the back of a discussion with the Care Quality Commission, they are interested in coming in to do some work with us. And I think as a regulator, it would be, in my view, helpful to get their view of how the organisation is doing on that data. I've also said a couple of things just before I finish around saying I would like to formally invite non-exec directors to contribute to terms of reference to these pieces of work. I also want, again, subject to board approval, to invite the BAME Network to contribute to those terms of reference. If people can let me know if they're interested, we will go there. And then finally, we will do what we always do, in my view, which is report report this openly and formally through the public part of the board. So
Thanks, Jane.
I'll ask for what approval on those 4 areas.
Lovely. And just to acknowledge as well, I know, thank you, acknowledge that my inputs along with your executive colleagues, but also I'd like to just note my non-executive colleagues input in various meetings and committees where there's been others discussion as well. So that's all been factored into these sort of steps going forward as well. Right, so we're talking about now board approval in terms of.
So just,
Yeah.
I didn't quite understand what you were saying.
Yeah, just that we have around our subcommittees and things as well, that we have non-executive input around things like the res and the des. And also, obviously, we're linked into the network, so we give feedback around anything that we hear from networks and that sort of thing. So it's just to acknowledge that it's a kind of it's a joint team effort in terms of discussions.
So, sorry, I should have been clear. Yes, you're absolutely correct. I said none of this cuts across the governance of our organisation.
Yeah.
My expectation is the executive will do the work and the non-executive will
Yeah.
assure through the board processes.
So a couple of things. One, appreciate the invitation as NEDs to be involved in terms of reference. What other opportunities will there be to be involved in the review? Any or not?
So as described, I think the executive are commissioning the work,
Yeah.
and the non-executive are there to ensure that the work is appropriately assured in line with the terms of reference. And if there are specific areas where a non-exec wants to get involved, by all means contact me and we can build that into the terms of reference if it's appropriate.
Okay. And then the second question, and I guess I've got my sort of former director of HR hat on. I was just interested in the rationale around the using a barrister for the external review.
So in combination of 2 factors, one is there is a very clear desire to ensure that from an employment law perspective, we are absolutely on it, but not only that. This particular barrister is a national expert in EDI and employment law. And there's a difference from our perspective, having spoken to the team, about having a policy to follow and how that might consequently impact on different staff groups and how we can be gold standard rather than ticking the box. And she has that expertise of looking at policies through different lenses and understanding how what something written on paper might actually play out in an organisation and be perceived by different groups within the organisation.
That's helpful because with respect to any legal professionals,
Yes.
they do take a particular stance sometimes. So it's good to hear that they're picking up the cultural aspects as well.
You are spot on, and we did think long and hard about whether we wanted a purely HR professional to look at this.
Yeah.
But actually, because of her sort of qualifications, sort of experience and expertise in the EDI field, we did feel that she would bring that different lens to it.
So that'd be interesting to know who that is.
I was just going to say we can share the details, can't we? Because there's information online, obviously.
Okay, thank you.
Okay, so there's a comment. Sorry, Hayden.
Thanks, Joe, very much. Welcome the external reviews. I'm very happy to contribute anyway. It's helpful. I had a thought and a question. So the thought was around the use of the word equality. Would equity perhaps be better to frame of the equality? To explain why that's.
Yeah. No,
So equality, just giving everyone the same
Same.
thing, whereas equity, giving people the right things they need to achieve a similar outcome.
Yeah.
Yeah.
No, absolutely.
And then the question was around timescales. How quickly will this happen? When can we expect feedback?
So I'm committed to feeding back in every public board as appropriate. These issues were raised to me formally 3.5, 4 weeks ago. Significant progress has already been made, and I commit to feeding back in every public board. I don't know how long the work will take. I don't know I don't know the timeframes of the individuals involved, so I can't commit to this stage. We will do it as quickly as we
Thank you. Part of my question was around timescale, which you already answered, but I think obviously that's quite a lot of work. So, and I'm probably not aware, but is there context for this? I mean, what's the context behind these? Because it looks like there's a lot of work that's being done, which is great. But is there context behind this, or the reasoning for this at this point of time, when we've got other pressures and everything else going on as well?
Yes, absolutely. And the context is that it's been raised with me a number of concerns, and I am doing my job as the chief exec and investigating those concerns.
Deb, I think the other thing to add to that as well is around the discussions we've been having around the workforce development, and also staff feeling they can come to work authentically, if you like, and feel the opportunities and things the same, because the outcomes are that obviously when people are happy in their work and outcomes are better, productivity goes up. I mean, that's using from more commercial sense, and from our point of view, it's about patient outcomes are even better. And I think we've been having discussions around that for some time. And actually, this piece of work, yes, there's a lot here, but we know that the outcomes will be, to get things right, we know the outcomes will be very beneficial for our patients and for our members of staff as well. So in a sense, it's a piece of important work, which, yes, is in addition to all the other pressures that we've got in the system, but it's sort of work. And funnily enough, it links back into some of the presentations we had in Black History Month with some of the speakers that we had, is that, you know, this is an area that we need to focus on, because we know we will have positive outcomes. So actually it's important. It's not just around delivering, obviously, what East of England and the NHS expect us to.
Sorry, I understand concerns, and yes, there's challenges. And what is the change that we are expecting that will come out of this? Because this could go on for a while from what you've said.
Yeah. So interestingly, when you look at our staff survey and you look at our res data, it's not me saying it, we are performing relatively well when you compare us to the NHS. We are very clear, and so that's not me saying it, that's an external expert. When I look at our organisation, I know that we can do more to support minoritized voices and the lived experiences of individuals in our organisation. And it happens that we have been doing a lot of work, and we are pulling this together into a programme on the back of a number of things that have been said to particularly me and others, to ensure that our organisation sees the work that we're doing and that we're taking this important agenda seriously. And for me, time frame wise, I recognise there is a desire to say, okay, when can we say we've done it? The reality of this is having somebody look at our HR department and their policies and processes, that could take a week, and they could come back and say, actually, everything there is absolutely stellar. No concerns at all. They could come back and say there are a couple of areas that we really want to examine in a bit more detail, understand the whys and wherefores, and that can take a significant amount of time. And we don't know that at the moment, which is why I can't commit. I think to get a commitment that we will publicly report back every time, every public board will evidence the interest that we're making.
So this is a difficult question to answer until you've got these people involved. So I know we're in a bit of a circle in some of these. But with respect to item 1, Joe, do you envisage that you will not have to, but you would want to communicate this work to staff?
Absolutely.
And then consequently, have we thought through what might be the implications for resources? Because the worst thing you want to do with lots of things like this is to start something that you haven't got the resources to follow through on, and the commitment and time that is the exec. Is that, I know it's a difficult, because what am I committing to? You don't know until you've got the study. I realise there's a chicken and egg question in
It's like you said. So absolutely clear. The reason it's in the public report is, like, as far as I'm concerned, everything in this organisation, we have nothing to hide, and we will be formal and open and transparent about this work. And this will, a summary of this will go into my weekly newsletter tomorrow, where we know at least half the organisation read it. So this is we tell our organisation what we're doing. We genuinely have not. So absolutely yes, your resources point is valid. Two points to that. One is we know that we are going to have to resource this properly, and that it's not an overnight fix with a few quid here.
Yeah,
it is something that we have chosen to invest in. Second thing is, we know that we can do more as an organisation. So I don't expect for 1 second to get some of the country's best experts into our organisation for them to turn around and say you are the best.
Yeah.
Because we know that the NHS as a whole could be better, and we know that we could be better. So my expectation is there will be a series of recommendations that come out of this. So I'm relaxed and open about that, because I know. I think the final bit for me about we will look to both Danielle and Kate in terms of the work across the organisation. The reality is, how do I ensure that when we speak to our medical workforce, as an example, where we know that 70% of our medical workforce is from a BAME background, that Ian is an ally for that workforce across all aspects of equality and equity, taking your point. And it's not everybody looks to HR. So it's how do we as a team step up?
and I guess building on that, I'm sorry, I'm not getting you anxious to jump in, but one of the things I would observe is about how you manage change programs and the setting of expectations. And so thinking through not just what to be done, but how we do it and how we get quick wins, and we don't set expectations because this is a 2-year change program and people go, and they don't hear anything. So I think setting it in the context of the work that we did and the discussions we've had about how we run good change programs is also something you should factor into this.
Yeah, I absolutely completely agree. And I think communication, engagement, involvement of staff will be critical to being able to deliver this programme, because it's going to rely on people feeling safe, able and supported to share lived experience, and for us to say what we're going to do in terms of changing that lived experience, if that's one of the actions that needs to come out of that. And it definitely will be, because we know that people's lived experience at the moment isn't always as good as it needs to be. But also in providing appropriate support infrastructure to staff as they share that experience, because we're asking people potentially to share really difficult, distressing things. I was in a session yesterday nationally about women's safety at work, for example, and we put a lot of support infrastructure around that session to really share different experiences, and we'll do the same thing. We're able to run the infrastructure around people and groups and something like the appearance we want to be able to do to engage in this, even just to engage in this work, because actually it's going to be tough to ask people to engage in potentially as well. So yeah, there's a lot that needs to, which we'll bring back to the board in a more detailed form once we've scoped up in terms of the filtering.
And last, I just want to say I'm in the 50% that eagerly looks forward to your weekly report.
Well, there's so many comments I could make.
Questions, yes.
Morning, everyone. My question is really around, it's great that we're obviously going to be looking at data and engaging with staff to understand their own experiences. But my question is really around what efforts and have we actually considered, what have we considered in terms of creating that safe space? Because I found in a lot of these interventions, it's really important to create a level of trust and for people to really honestly give feedback, so that the data that is then used to allow those interventions and potentially that strategic change management process is quite intentional. So I haven't heard anything about how are we actually intentionally going to create an environment of trust and that psychological safety, because people will tell us what they want us to hear to an extent.
So part of the reason for ensuring that we get support to do this is to get experts in who have been through this before and understand how best to create spaces that are psychologically safe and where individuals and groups of staff are able to speak up. And for me, it is demonstrating as an organisation the fact we are signed up to this as a board and that we are prepared to invest in external and internal as required individuals and time to create that space. So we don't always get it right internally now, we know that, and that's why we've got some of the country's best people coming in to help us.
And I think as well, it underlines the importance is getting, and obviously this is outside the meeting, but getting colleagues' feedback around terms of reference. So it's going to be important for us to make sure that everybody has that input into it. But
I think John.
Yeah.
I mean, this is, I suppose, an observation born out of a bit of frustration that, this is all going to cost a lot of money because you're bringing in some really top drawer people, which is great. And I'm glad we're doing it, don't get me wrong. And it's just, I've seen over the last few months the business case for the cultural intelligence work get batted back constantly. There's not enough money to have the resources to put into that. And I appreciate this is done on the back of concerns, so we have to address that. But there's just something for me that's just doesn't sit well, that we've rejected the ability through finances. We've chosen to spend money on different things and wouldn't do the cultural intelligence work. We'll kick that into the long grass. And I appreciate now that we're going to have to spend a lot of money on concerns. So there's just something that just doesn't sit well with me.
Let me put that in context then. I said when I started this piece that externally the evidence says that we are one of the best performing organisations in relation to this agenda. So when we as a team assess and evaluate how we spend our money, we clearly look for our money, taxpayers' money in relation to the 360 million. We clearly look for those areas where we can need to make the most significant improvement, and we are an outlier in terms of performance. So I think when we were looking at those cases originally, we felt that as a relatively high performing organisation, there were other priorities that we could and should be spending our money on. I think two things have changed. One is absolutely individual concerns have been raised that we as a board want to ensure that we address fully. I think secondly, and Terry will come on and talk about this in a little while, is that organisationally our finances have been improving, and therefore we do find ourselves in a better recurrent position than we were at the start of the year and indeed at the end of the last financial year. So as always, context is really important in this, and I think we are in a better position now to evaluate and determine this is the right thing to do.
I think my own, I don't want to prolong it, but my own response to that is when we looked at the evidence from Lincolnshire about the impact on patient care was through investment in things like cultural intelligence. So it's not just about attacking things in terms of where the performance is low. It's about upstream. Actually, if you're treating your people right, they'll treat their patients right. You'll improve performance. So it's what end of the telescope we're looking for.
Completely right, and you used the word frustration when you started. We had a senior team away there yesterday, which involved the divisional triumvirates of our doctors, nurses, AHPs, and operational managers. And interestingly, they were describing a frustration that they had had at the start of the year about their ability to get on and treat as many patients as they possibly could, outsourcing and trying to reduce the waiting list as quickly as they possibly could. And if you recall, we had a conversation as a board at the start of the year that we were not able to do that because of our financial position. We've moved over the last 6 months into a place where we are now doing that. And again, they were expressing frustration from a clinical treatment perspective about how as an organisation we weren't able to do something, and now we're saying we are able to do it. So I think what you're describing, what they described yesterday, is where unfortunately as an NHS we have found ourselves somewhat over the last sort of 18 months, 2 years, with a level of uncertainty around funding and a level of uncertainty around how we can use that money in what is a very, very difficult place. So I think we are fortunate to be where we are now.
I appreciate that. It's very easy to put money into prevention rather than cure. I appreciate that.
But I think as well, I mean, I'd just like to acknowledge actually having this conversation is important as well, because I think it's around learning, looking back on decisions, why they were made at the time, what the context of the time, and actually looking forward. Well, there's no reason why we can't actually change that focus and say, actually, no, this is where we now need to put our efforts and put our money. So I think it's, if we're going to apply the appreciative inquiry approach that we want to through the organisation, I think that also applies to the board. So I think it's right that we look back and reflect and then say, okay, we'll take things forward in a different way. John.
Thank you. So this is obviously a work to be able to take using the existing metrics that the NHS relies on. I think as Joe already said, we are, on the face of it, above average, doing well. I just wanted to possibly ask if we could get reports written in such a way that other organisations outside of NKH could pick up this report and challenge themselves to see if they meet whatever the findings are, so that other people could benefit from an organisation that, on the face of existing metrics, looks above average. And if there are findings which as you might expect that we can do better, that other organisations will pick it up and say, I wonder.
Yeah. And certainly, I mean, from my perspective as well, being just in our own system, actually, this is something that, as the findings come out, I would very much want to share with colleagues at the integrated care system as well, because obviously we've got other providers across the system, and there's no reason why we shouldn't share that learning. In fact, it's very important we share the learning. Okay. Thank you very much. Thank you for everybody's input. And then just to stress as well, colleagues, please, some input around terms of reference, and obviously we'll ask our main colleagues as well to be very helpful. Don't you want to click on that, David?
So yeah, just a couple of other things there. So I'm assuming that I put the proposal for support section because the conversation not going to it's good. Secondly, then there's the BLMK ICB update in there to note, and also the Denny review of qualities across BLM to note, and that will no doubt form part of the agenda of the ICPA.
Absolutely. And hopefully, non-exec colleagues, I did circulate it to everybody, because what happened last week, we had the partnership meeting this week, as I mentioned, for the integrated care system. And they were interested to have any feedback from colleagues, from providers, from our boards in particular, around the Denny review. And I can feed that back on our behalf, and then that will be used going forward. So yes, the ICB will be using that review and other information that they have in terms of those strategic plans going forward in terms of population health across our system. So look forward to any comments that you might have.
Well, just email them to you.
Sorry?
Just email them to you.
Yeah, that'd be great. Yeah. Oh, I'm very happy to meet over coffee. It's nice to have face-to-face to start, but no, email would be fine.
If they're dating,
I think they, if you could get comments to me by the 9th, I think that's next week, that'd be brilliant. I mean, obviously I can feed it in at any time, but that would be helpful, because then I know that they're hoping to take that to their board in December. I think those are the dates that they've given me. But I can check the email. I'm pretty sure it's for their board meeting in December, isn't it? Yeah. Okay. So that'd be really helpful. Thank you. Okay. Any other? Okay, thank you very much. Thanks for that. So, and we go on to serious incident and learning report.
Thanks, Alison. So item 8 on the agenda, the big pack, page 75, is the serious incident report. So first of all, there's some confusion about whether 8 or 9 SIs reported in September or October. It is 8, as described in the table. I think of the ones in the table, I would note the case of a patient who sadly died of an opioid overdose following discharge, which was subsequently subject to the prevention of future death communities. There's also an incident there around endoscopy, and the patient who died following an endoscopic procedure. And the third one to highlight is around gentamicin, which is an aminoglycoside antibiotic. It's an antibiotic that obviously has benefits, but also comes with risks. I'll come back to those 3 themes in a moment. Within the paper, there's information on the themes of incidents generally and the learning that is going on. From page 80 onwards, there's some detail around some coronial inquests, some that have happened and some that are happening. We previously discussed the board a few themes that we're concerned about and that we've noted in our incidents profile. One of those is around sepsis and recognition of deteriorating patients, and we're doing a piece of work on that. Second is various complications that have arisen in the hospital department. So there could be some work around that to bring in outcomes and complication rates. And the first cut of that data is that they're absolutely within expected limits. And the third thing is around antibiotics. So, as I said, gentamicin and vancomycin and other antibiotics, the aminoglycosides can be quite dangerous. They've always been quite dangerous in overdose. They're great antibiotics when they're indicated, but essentially they can cause either kidney, with some hearing difficulties if they can. We've got electronic patient record, electronic prescribing, which gives us the opportunity to put lots of safety measures to reduce the inherent risks of these antibiotics. I think generally speaking, we've done all right about that. One of the issues there is that there is an inherent issue. It's much more visible because of the electronic prescribing. So we're working through a sort of quality improvement program, working with clinical staff and human factors, but also our electronic prescribing system, try and improve things in that matter. And one of the inquests that's coming on will be, I'm sure we're looking at that in relation to one of the lessons. Stop there. Very short cases as well. Any questions?
I just wanted to highlight the very last bit of the report, which is that the Health and Safety Executive is going to inspect us in January. We're one of 20 trusts that they're inspecting just at random, I think. We've had a pre-meeting with them. They're coming in to inspect us on our approach to preventing and managing violence and aggression and managing musculoskeletal disorders and staff. So they're likely to come in for a week or for at least 3 days to look at our work program. We've done a lot of work in this area, so it's the first time we'd have had an inspection by the HSE.
Assuming you're in January 2024.
Oh, yeah, that was not my strong point.
Backwards. Is that, and that's something, I mean, the HSE do this sort of thing, don't they?
Oh, yeah.
Actually, in all sorts of areas, I know,
Yeah,
in other sectors as well, I know they
Yeah.
go in, don't they, to see what's going on.
I think actually it will be really positive because
Yeah.
there'll be a lot that we can learn. Hopefully we can pick up on good practice elsewhere. We can close any gaps in our work program.
Yeah.
If there are any. So I think it should be a positive
Yeah.
experience in terms of
Yeah.
learning.
I think that the external review in all areas is very helpful. So and peer review as well. I mean, that's the other thing is within
Will they be looking at the risk register as well?
Yeah.
Because there's an awful lot of
Yeah.
risk related to health and safety.
They're great. They're taking their approach, and one of their themes is around risk assessment, and then what you do as a following that risk assessment. Yeah.
I'll look for colleagues. Sorry, Hazel, did you have a question there?
Just that it wasn't a question, just to say great work on, it's great to not see pressure ulcers on this. And, you know, I read with interest the note on the quality improvement program and reducing pressure ulcers. So really, really great work.
Did you want to?
I just wanted to talk about these coronial inquests and what are the sort of risks for the trust from that.
So, yeah, the first thing I'd say is I genuinely welcome coronial inquests. Obviously, I can welcome them or not. They're a legal entity, it's a statutory entity. But for me, it's quite helpful having care looked at from a very different and objective perspective. Clearly, the risks essentially are if a clinical incident or a medical error has contributed towards a death, or it feels we don't have appropriate processes in place to reduce the chance of that happening again. Now, from my perspective, electronic prescribing, electronic records are in themselves a really important safety measure that we've chosen to implement. I think the concern I've got is that because they contain information and data, sometimes electronic patient records get blamed for the incident, which I think is generally unfair. That's one of the issues I'm concerned about. Sometimes innovation ends up being criticised. That's one thing. And then there's also, it's quite a focus on sepsis nationally, clearly. And as we've discussed in quality committee, sepsis, of course, is an important preventable cause of death. For me, two foundations of sort of having successful care for sepsis is firstly triaging patients when they arrive, so we know roughly what's wrong with the patient very early on, rather than having people wait for visual diagnosis to be made. And then secondly, when an inpatient, noticing that somebody becomes unwell. So the new system of monitoring physiological signs and then the escalation that happens as a result of that. one of the cases we've looked at recently, which said that the procedure goes to the ward for endoscopic procedure goes to the ward for observation. Again, we're using the new system and people feel secure because they're using the new system and monitoring a patient. The new system, of course, is designed for patients who are unwell in hospital. It's not really designed for somebody who's come from a procedure or coming off the street completely well, then goes to a ward for observation. So there are all sorts of nuances. It's the balance between pragmatism and good sense, and some of these processes we've put in place for good reason.
Thank you. Just another one on this, actually, around that violence, violence and abuse one. Obviously, there was recommendations made, and you said that it's been escalated through the ICB and the CQC, but is there anything else that we're doing proactively internally in terms of identification and prevention of these kind of incidents?
So yes, I think first off, most organisations around the country are recognising violence and aggression is getting worse. And they're also recognising, so I was at the regional meeting earlier week, and lots of concerns still around patients with mental health issues in not the most appropriate places, such as the emergency departments. You'll recall, of course, the right place work with the police, the police wanting to step back from lots of this interface work, and all of that is sort of coming together nicely in some ways to sort of lead to issues. Perfect storm. So we're doing quite a lot of work. For example, it's very easy to say zero tolerance, but actually to ask ourselves, what does that mean? So we're doing quite a lot of work on that. We've got body cams on various staff members and carry on looking at. We should be following that up. Lots of work going on.
Ian, can I just do a follow on from that and related to the previous point around ICB role? Because is there a role, are there issues that get carried to the ICB because mental health and people who are here who really should be elsewhere? So it's a bit difficult for us to solve that problem in MK alone, isn't it?
So one of the early successes of the ICB was we now have eight beds for children to help children in Bedfordshire, which is better than not having any beds.
I didn't know that.
I think my slight anxiety about the ICB leading work around violence and aggression, for example, is that mental health trusts and more important police forces also respect the M1 and different police forces. Therefore, if there is lots of work going on in Bedfordshire around this, they will not be applicable in local instance. So we need to be having those parallel conversations.
Yeah, that was recognised at the partnership meeting actually that I attended, and they acknowledged right from the start that we've got two different sort of systems, two different police forces and things like that. But obviously we've got trusts that are trying to work across the piece so that you get the same set of standards. I'm very conscious of the time, everybody, so I'm sure if there are any other questions, please do raise them afterwards if you would like to. But I need to just move on to the next agenda item, which is around the mortality update.
So still with me, I'm afraid. It's not in the main agenda pack, but it is on IBAPS. This is item 9. So mortality report, as usual, there's qualitative data and quantitative numerical data. It's largely unchanged. Generally speaking, the expected range in terms of the numeric areas. And we've had lots of previous discussions around impacts on electronic patient record on some of these metrics. We've had discussions around preventive care, coding generally, etc. How all of these things can play out on. I think there is one new issue to point out, and it's an issue that makes the reliability of the data less good, and it's highlighted in the report particularly. Firstly, the proportion of our cases where signs and symptoms are the diagnosis is high, as we discussed previously. Secondly, the number of patients who are admitted via the emergency department and then have a 0-day stay has shot up. And thirdly, number of admissions where the episode is completely uncoded has gone up. That's what Appendix 3 says. There's a number of 17,000 such episodes. You recall Joe mentioned earlier the same day emergency care unit over 3 years, 60,000 patients. Those numbers are very similar. It's about a week or so. But I think the issue is that those people who contractually, historically, for many years, agreed to treat us as outpatients, if they don't get coded, they, because we're using the electronic patient record, have been submitted to the data set as inpatients. We'll go in as uncoded inpatients and make all the data somewhat unreliable. We need to understand that and fix it. That said, when we fix it, it will take 14 months or so to come out, sort of rolling 12 months. So that is changing, but we are now aware of it.
Can I just ask you, is this a format that's required to come to board? Because I mean, it's not my strong point anyway, but I mean, I really do have to work quite hard to go through this to understand all the data.
So from my perspective, I believe mortality can be dealt with at a subcommittee. So obviously these reports do go to the Quality and Safety Committee as well.
We've had a teaching.
You have had a teaching session, so
Yeah.
some of the groups very well aware of the figures.
Yeah.
I'm very relaxed about how it gets managed going forward.
Yeah.
I would tend to agree this is probably too detailed for.
Because I was just thinking, particularly as this is an in-public meeting and people are seeing this, you know, how much, obviously there are some people who are brilliant with statistics. We've got quite a number around the board who I know are. But I'm just thinking in terms of it being understandable in a public forum, it'd be quite handy. Perhaps if we can look at how this is presented. Sorry, Heidi.
Ian, I understand what you're saying about the numbers and the 14 months. Are you saying though as well that we'll recut what we've got once we understand how it's changed, so that you would still have a year-on-year rolling 12, 14 months of?
So no, after coding has been frozen a couple of months after the episode of clinical care, it can't be changed. So it'll be looking forward. Now, most often when other trusts have got themselves into a difficult position, it's because the HSMR shot up to 140 or so. Thankfully, that's not the case here, and we're still within control limits.
But that does mean effectively we've got to live through period of
So it does, but also, and my message has been consistent the 7 years I've been in the trust. Quantitative data, yes, it's interesting. Yes, there's stuff you can tell from it. Actually, it's pretty flawed because it's only as good as the quality of data everybody around the country is putting.
Yeah. And
the game changer over the last 7 years has been the qualitative side. Medical examiner review, my objective review of individual cases. So we're in a slightly different world because that's now.
So in a sense, it's pulling out the valuable aspects of it that we could have in the public domain, because then it makes it much clearer for people.
I think Quality Committee is the place with some assurance to the board around that overarching stuff. It's probably better.
Yeah. Deb, looking to you as you chair the committee. Happy to take it on board and stop. Thank you very much. It's volunteered.
We did already go through that in details. It's replicated.
Yeah, brilliant. That's great. Thank you very much. Thanks, Ian. Going on then to, sorry, I didn't look around. Any other questions? Maternity Assurance Group.
Thank you, Alison. Colleagues, this is the briefing paper on the Maternity Assurance Group. There are three key areas I'd like to focus on. The first is on our birth forecast and capacity. You'll see that we're expecting an increase in the number of individuals who are birthing here at MKBridge in November and December. There's quite a detailed piece of work that sits underneath that to ensure that we have the appropriate workforce available, and how we manage our inpatient, antenatal and postnatal care wards will be different in order to manage that demand. And we're currently working on the workforce modelling. We will be looking in very close detail and have already started to unpick some of the length of stay, particularly post-section. The other component to that is also theatre capacity. So we're looking at our theatre capacity in terms of C-sections in preparation for that increase in the number of individuals who will be birthing here at that time. So that's a very, very important piece of work, and it's taking up a great deal of time at the moment. The other part to highlight is around the midwifery workforce. The business case has been done for the uplift for the 6 additional registered midwives at band 6, and that brings us in line with Birth Rate Plus. That has progressed really nicely and is going through the internal trust approval processes. We've also managed to maintain Labour Ward Coordinator supernumerary status. It's a constant and daily challenge, but we've succeeded in doing that, and that remains at 100%. Then the final thing to perhaps note from MAG that's of interest and requires our attention is as a system, this is for BLMK, we've seen an increase. This refers to data from November 2022, an increase in stillbirths. There is a regional deep dive into and thematic review that's ongoing into the stillbirths from BLMK. We have really robust processes around our stillbirths and had already done a retrospective analysis quite some time ago. So many of the things that you'll hear us talking about in MAG in particular around smoking cessation and CO2 monitoring in pregnancy, I anticipate that will be linked into whatever thematically comes out of the BLMK review. And that's the main issues from MAG.
Just to say CO2 is carbon dioxide. As we're in the public. Any questions? I mean, I'd just like to know, because obviously I sit on the maternity assurance group, and there's extraordinary amount of work that's coming through nationally constantly, and it's changing sort of aspects of monitoring and that sort of thing. So there's a huge amount going on in maternity. So this really probably doesn't quite reflect that the enormous amount of work that is going on. And thank you to colleagues for all that they do. Actually. Any other questions? Much. Safeguarding.
Thank you. This is me again. So some key issues to put out of the annual safeguarding report. You'll see that we've done quite a bit of work in strengthening the safeguarding team. There's very strong leadership in there. Now we have an associate chief nurse who leads up safeguarding. In addition, we have a head of safeguarding. At MKUH, our safeguarding is complex and detailed, particularly around the care of children and young people. That is an area of focus and probably reflects our population at the moment. A key area for us and a focus of attention is around the attendances at the emergency department for children and young people with mental health problems, and trying to support and facilitate the repatriation of that individual into care facilities that are appropriate to their needs. That is something that we probably deal with in great detail every single week. It's a similar picture on the adult safeguarding perspective, particularly around mental health, and that is about ensuring that people have access and timely access to appropriate care and treatment, and that might be from social care or from mental health colleagues. There is an enormous improvement programme around safeguarding. So this is more about process and policy. So we've looked at, as the safeguarding service has expanded in MKUH, it's making the policies and procedures more robust, clearer, and more transparent. That is a long and detailed piece of work. We're about midway through that. We've got we've appointed a clinical educator around MCA and DOLS, and what we'll be looking to do is to make sure that those safeguards are embedded deeply into individual ward areas. They have tended to, and this is probably a reflection of small organisation moving to a larger organisation, they tended to be managed from the safeguarding team. So equipping all of our clinical colleagues to be able to manage that process locally is a key area of activity for us. That's really the overview of safeguarding. It's a very, very busy department. We've got lots of new appointments, and so it's a much stronger and improved area of practice.
Interesting. I don't know. There's some headlines recently, actually, sort of nationally, I think, around some local authorities in terms of them meeting the requirements for safeguarding. Things it's going to have a huge impact whether or not they can deliver on what's needed. So that I think this just reflects actually what the national picture is very much as well.
We touched on this earlier with the mention of the police and the changes in terms of their response to the national change, which obviously we'll see here as well, in terms of their response to mental health crises, people in crises. And I think it's just worth noting for the minutes that it's a challenge. It's really challenging at the moment in terms of being able to support patients in the right place, particularly young people who need complex social care placements often, who aren't under a section of mental health act, who are waiting a placement. We're doing a lot of complex work with partners around the appropriate legal frameworks, the right place for care, but we are holding the risk. We are for patients in our organisation, patients who shouldn't be here. This is not the place that they need to be. They need to be in a different placement, but they are with us because we are the only safe place available for them. But the risk then all sits with us organisationally, and I think it's a really important point to make in the board for the minutes as well around how we manage that on an ongoing basis, because there are risks to other patients and to our staff and to us organisationally, because And we are, not a mental health board, so we can find
That would be a prime example of one of the risks we should elevate up to the ICB and say, you need to solve this.
Yeah. Well, I think they are aware, but yeah, it's not an easy one.
So I think just to sort of extend on that, recently we've been discussing cases where we had actually thought as an executive team we might need to take legal action against them, not a local, but another local authority. And just that's bizarre. Two public sector organisations saying a legal route may be necessary, but it really is quite extreme.
Looking at the outcomes for the individuals concerned, actually, that's the primary focus. It's a very difficult situation. Just a couple of things for me, Yvonne. Presumably, we're looking for a head of safeguarding, but is there sort of the perhaps the lack of numbers of people for those posts a national issue in terms of finding somebody to recruit?
It is. So we've appointed a head of safeguarding. She's been here for about 12 to 16 weeks. She's very, very good. I'll have her come and visit you. So we've been very lucky and we have been successful. The bit that I'm having a struggle with at the moment is it's the pipeline into the head of safeguarding has all of the expertise to bring people through so that they have the right expertise in what is a complicated operating environment, both from a legal perspective, but also from a practical, clinical perspective is the larger challenge. We have committed to quite a bit of education. So anybody who comes into the safeguarding team now has a formal education and training in safeguarding. And in addition to that, we've seconded people into the role and given them lots of support and training before we make a final decision on whether safeguarding is actually for them. And it's largely because it is a really challenging role. It's often frustrating and your wins are small. So I'm confident we have a really good and robust workforce plan. I think we will be fully established in the next month. But it's difficult. It's difficult to get the right skills.
It's difficult there. And just one other thing, and because we mentioned about the care plans for people with learning disabilities who come in, and it just occurred to me that we're going to do that piece of work with the Spinal Injuries Association in terms of emergency care planning for people who come in with spinal injury, so it flags up on the ESR. I'm wondering if we can kind of use a similar, if it will be appropriate to use a similar sort of approach, so we have something in place that flags up when people come in.
Absolutely, that those two would dovetail together really very neatly. They're very different, but actually the process would be very similar. And our new adult lead for safeguarding is also the lead on learning disabilities, so that fits very nicely for us. So that she starts next week.
Thank you very much. Thank you for that report and your complaints report.
I won't spend too much time on this because you've seen all of these numbers before in audit reports, and so it's quite an old report now, way through the different committee structure. So I'm happy to just take questions. I think it sets out, complaints are increasing and they are increasing in complexity. That's the trend that we're seeing continue into this year as well. And obviously we're doing quite a bit of work around how we manage complaints in the organisation to make sure that we give timely responses, particularly where those, and we sit down more frequently with patients and families to work out concerns to stop complaints that are coming back into the organisation so that we get a good resolution the first time. One piece of work we're doing this month is around restorative care, so doing some training with complaints and governance teams around engaging with harm families and patients, and how we bring in the principles of restoration and of care into how we can responsive. That was
I've just got one thing to note is just well done to the complaints team because they've increased, I think it's the target for resolution within 24 hours. It's gone up 10.7%, but in terms of comparison for 21 to 22, I think it's just over 20%. So I mean that early resolution is so key actually in the complaint side. So that's good to see. Hey.
Thanks. Kate, just wondering the top 5 complaint issues, the top 2 are communication and appointments. Both of those could be, or there's some patient portal functionality that is being used that could be extended. I was just wondering if we feel that our patient portal roadmap will actually help bring these down.
I think so. So I think that because they are our two biggest areas, we're doing lots of work pulling in all the different data we get through the various different places to understand exactly what the issues are. I think a lot of them are probably driven by equipment changes. And so due to all the reorganisation. So, but equipment has been it's a long running theme. I think it's particularly exacerbated by recent sort of need to reschedule. But you're right. There's some functionality that we can tweak and we can incorporate and get notifications, making sure that we don't duplicate my data, for example. So we'll do some work. On that. And then communication is a really big theme. Is challenging because it's behavioural, it's process, it's all of those things.
Excuse me, any other questions at all? Just one presentational thing I can pick up with you outside as well, but it's just on, I think, on page 8 and 16 of the report, there are some colours missing on some of the charts, so I couldn't follow, but I'll just let you know which ones, because I couldn't follow where they were.
Okay, sorry.
Don't worry. Okay, thank you very much. Annual patient experience report.
Yeah, so similarly, this comes as part of our sort of quarterly reporting through the board. So these are numbers that you will have seen before. There's lots of really lovely work. I also expect the report, but there's lots of really great work in here, from a huge number of different groups as well. So everybody, the patient experience team coordinate lots of work with the charitable sector, with sponsors, with external partners, volunteers, going to the community to do work in the trust to improve patient experience. They really bring together a lot of different bits of work. There's a couple of bits I wanted to pick out. One was Sign Live, and to give just to commend Sam Penny, who's really led this project around improving access to British Sign Language interpretation for patients. Really important piece of work, and really pleased that we've been able to bring an innovative tech solution actually to what was quite a difficult problem in being able to get trained interpreters at the time the patients needed them. So we've been able to do that through this programme of work, which is really, really positive. Hopefully we'll see that improvement in our feedback from patients from that group. And again, happy to take any questions. Obviously, we've been doing a lot of work with the platform, so patient experience platform, looking at all of the data that we collect around patient experience and how we stream that into the various different thematic improvement works. We'll be doing some work with the quality improvement team around these big areas of work and trying to link that back into other care work and in the organisation. But we've got a lot of good to learn from as well. So lots of compliments, lots of great exes, lots of work that's really positive so that we can use through inquiry work and learning from excellence as well. So that's really positive. But there's lots of really good stuff in here. I do recommend it's well read because there's some really, really great stuff.
Yeah, thank you. Thanks. Any questions? Can I just ask what, I know from the partnership meeting I was in recently, where they were talking again about community connectors. Do we have a direct link with people that go out into communities who are, a direct link with our organisation? I know they feed back into the integrated care. Do we have any?
I don't recognise the term.
No.
But
I hope I've used the right term.
Well, yeah, probably. I think we do obviously lots of engagement work.
Yes.
I can pick that up and see whether it is something that it should be.
Well, I'm just wondering of getting more support from the MCB in terms of that community connection, because it's such a huge piece of work. Actually, the more support and help you get through colleagues as well around the system, the better. But it just seems a useful way of getting that feedback. Particularly thinking around our new hospital programme and stuff, which is referenced in here. There's a lot to be discussed and get feedback on about building that in the best way possible. Really. Okay. Another question. Thank you very much. Performance report. Thank you. Yeah.
That's fine. Thank you. So we're reporting September month 6, halfway through the year. Just to refresh people's minds, in months from the 19th to the 22nd, we had strike action, a combination of both the junior doctors and the consultant strike occurring in month. So from an ED perspective, we saw a slight decrease against the 4-hour performance, dropping down to 70%, against an increase in attendances. you'll see in the report, we do still our peer review against performance elsewhere. And that general 3% sort of trend and decline is reflected across everybody in our peer review group, which I think is the sort of seasonal changes that we're seeing. National performance, however, we were a bit below because 71.6%. So we need to maintain our performance within there. The bed occupancy within the organisation seems to be increasing. Our ambulance handovers were a little bit more challenged in months. And our non-criteria to reside that will talk about the patients that shouldn't be with us, still generally fairly static around 72. Within the month, we see peaks and troughs within that. Generally, we add on 10 patients a week in that particular area. The work going on with partners symptomatic of that. And when we work with partners well, we're seeing that number decrease. I think I'd just draw attention to some of the internal work. So the discharges from PDU was showing an upward trajectory, which is some of the work Yvonne's been doing with the nursing team, trying to get the day starting earlier on the wards, therefore movement out of the wards down to PDU and getting that transport booked early has been helping. As are fractionally, there's still a lot of work to be done, the ward discharges before midday. Again, we're trying to work hard on getting that so we're ahead of the curve. But it's a generally challenging position, and as of this morning, we're in a tight position on April 4 with just about every escalation bed we've got bedded. So clearly challenges in paediatric activity over the last 2 weeks has seen an increase. So we're definitely going into the winter months. From an elective position, the cancer data is included. We're still holding over 178 patients over the 62-day mark. A large proportion of those, 75% of them, are across all specialties, which we've mentioned in detail in some of our seminars: urology, colorectal, gynae, and head and neck. Therefore, impacting on the benign work with the cancer activity being so high. And 25% of that activity is urology. We've got some real challenges in urology cancer performance at the moment. Electively, our 65-week waits, we've discussed it recently, 954 waiting towards the end of the year. The ambition of that is definitely to get down to 0. More importantly, from an external perspective at the moment, we're still being highly scrutinised on our 78-weekers, and we've got 87 of those in month. We've talked a consecutive theme across this year, 35 of them in ophthalmology and 18 of those in TNO. And we are making some good progress on the inpatient TNO coming down to do that. Our November forecast sits the same, as we'll come on to discuss with the financial. We have started to execute some outsourcing now to make more activity be seen faster with external partners, and that's specifically focused around some of our vascular services and our ophthalmology work. And we are running consistently our internal waiting list initiative LLP on TNO between now and the 16th of December. They're already booked every weekend, so we've got patients on the list coming in there. So slow progress being seen in the numbers, but internally, huge amount of work going on to get those patients seen. From a diagnostic perspective, performance again relatively consistent, but I think in month we have put in an additional MRI scanner located up at the urgent care centre, and we've got an additional 400 patients going through that, and we would have done prior to taking that additional van. The positive news sitting alongside that is that those come with reporting capacity and staff capacity. So it's not an additional draw on our existing staff. It's been commissioned so that we can see that progress. So I think we will see that impact then helping the cancer patient pathways. And whilst we anticipate we'll see a dip in the cancer performance because we're treating more of those patients in breaches, we should pull back out of that relatively quickly. I think I'll pause there for any questions.
Thank you, Paddy.
In the Finance Investment Committee, we discussed the fact, obviously, we're trying to keep the hat of Finance Investment Committee and efficient use of resources being, and so we touched on the super standard and the non-criteria to reside on the point being that we are quite stuck on a number on both of those relatively. And I suppose it's just that kind of how do we point at that more? And I hear the immense amount of work that's going on across all of these pieces that are changing to our flow. But I think we were just talking about the fact when we constantly have that super standard and constantly have that non-criteria reside piece, what can the wider community do to help us?
It is about that system engagement and whether we can invest more community capacity of a different type or work more effectively. I know Ian is leading a piece of work that Julie and I heavily involved in integrating now the discharge team with the social care team in due course to try and bring those expertise specialists together, have a more seamless process, and covering some of those fall between the gaps in terms of how that's working. Essentially, I think the non-criteria to reside at the moment, we have a local philosophy and belief that we repatriate patients back home as the preferred option rather than sending them on to another onward destination. It's the right thing for patients, but often leaves us then with a longer holding period before that package of care at home is implemented and has got the capacity to do so.
I think that's an important point that it's not a case of just bouncing someone.
No, it could be, but we would still up. And yes. I think historically, years gone by, Milton Keynes, down other places, that's what happens. You commission additional capacity for winter, but actually you just move the problem downstream into a community environment.
Or you can the individual
yeah. So I think those are two things I'd point out that needed to happen.
Yeah.
Pretty much exactly the same point. It's kind of, is it circa 20% of our dates?
Yes.
Which if you put that across the NHS is frightening. And then you sit, and we're going to be later on looking at approving additional wards and space and spending. So I struggle to put that together. And it has been stuck as a number for a while. I know I'm repeating what Heidi said. Small point from me that might be helpful is I'm beginning increasingly to think it might be useful for us as NEDs to see those issues where there's a system solution to it and not just a Milton Keynes solution to it, so that we get greater clarity about those areas where it's very difficult in cancer pathways and a number of other things I can quote, mental health, and we begin to see some KPIs that we're looking for the system to help us move forward on. I'm not saying we push problems up, but it just might be a clearer way of us understanding what the value of the ICB is as NEDs, and because I'm sure it can apply the other way. So that's one point. And then one last thing. I'm still looking forward to the new performance report, which I know I raised at the same.
Yes. Yeah. Well, let's have it for January. That's the next one. So let's give ourselves a deadline to make sure that the new presentation, because we've seen it, haven't we, in March? Was it March?
No, we saw a pro forma in March. And we're working on it. I don't think we've seen the final version of it yet. It was brought. Do you like it?
Yeah. Perhaps we can pick it up.
It's been held back for Christmas, I guess. It's been a Christmas present.
We don't take public questions, sorry, but by all means, drop me a line. Yeah, thank you.
Can I just go back on one comment? So the other point to raise is about the out of area referrals that also get slowed down. So whilst we're doing lots of integration work across the LMK and in Milton Keynes, our number of Buckingham resident patients who take a slower proportion of time to again work with all Northamptonshire patients. So we call them out of area patients, but it's not as slick either. So when we look at our non-criteria to reside, there's a number of those patients. So similar to the safeguarding issue out of area of children, and that communication links, it's becoming more complex from an inpatient perspective too. It's just another dynamic to the numbers. Yeah. It's beneath the high level.
Thank you.
Yeah. And I think, as you say, if we have that to do, we can programme that in, because in fact, Kwame's dropped me a line yesterday to say we want some inputs from non-execs as well as the board around things we want to cover in our seminars next year. So we these sorts of things, actually, if we can have suggestions, certainly around the systems, possible system solutions. But I'm wondering as well, what was going through my mind is around probably a broader discussion on cancer services and treatment and all those challenges around that. And that may well be linked into some of the system stuff as well, which would be useful. So perhaps we can take that outside and program in something in a seminar where we can get into those discussions. Any other? Suppose it's as you say, we're going into the winter stuff now, so we'll obviously be watching and seeing how these things develop. I suggest we take, just thinking, if we take the next item, the GERFT, get it right first time. And then I propose that we then have a break. We can stick to the time for a break, and then we can come back and we'll start straight off with finance, Terry. So straight after coffee, that'd be good.
So I simply just pick out the highlights from the GERFT letter. Professor Tim Briggs has been doing a series of visits across the ICBs nationally over the last 18 months. I think this was our third visit. The first visit, I recall, he was very disgruntled with the lack of engagement across the ICB. We presented as two hospitals, and he didn't really feel there was much integration there at all. It's nice to see the positives coming out now, some months later. The highlights kind of in the feedback included the collaborative approach that's happening and the shared learning then that we are, if you look at some of the detail, we're not excelling all in the same areas, so there's learning to be shared across the curriculum. Clearly, the emphasis is on protecting the elective flow through winter. And again, the success stories of keeping that activity, productivity going through. He pulled out our 22 cases on the cataract list. He looked at our paediatric surgery days, of which we've been dedicating theatres just for paediatrics. We've got through sort of 45 patients within one of those sessions. The latest request from another external review is we need to be doing more of them more frequently in order to keep that going. So the request is always to do more. But again, we've got some work to do, and it highlights our day case rates are there to be challenged and still got some work to be done. Our capped theatre utilisation rate has moved significantly in the last year, and we seem to be up there at the top. So nice to have some positive feedback for the teams to keep them going. Areas around the mental health and kind of the emergency flow through winter obviously highlighted, but it was just to give the board some assurance on what the outside world are seeing across BNMK.
Any questions? I just noted that lots of acronyms in your feedback, you know. No. I mean, that's not, I mean, this is his letter, you know, but it's interesting. I don't know whether presumably he expects this to go into the public domain. I don't know, but anyway.
Well, I'm happy to, if we need a glossary to add to the paper, I could add that in behind, and I could get that published. Yeah, but it is a bit challenging.
It's but as I say, it's you know, outside the organisation, and it's just interesting to see his approach as well, you know. Okay, thank you for that. So if there's no questions, I propose we just have what we're going to have 10 minutes. Yeah, 10 minutes just for a comfort break and grab a cup of coffee, and then come back for 5 minutes.
Yeah.